What do you hear now? Lumpectomy. What is that? That's focal therapy of breast cancer. Coming a little closer to home in urology, it's happening in prostate cancer. And so let's talk about it a little bit. What's the idea here? We want to remove the problem that we have, whatever it is. We want to eliminate the cancer in this case. We want to preserve uninvolved tissue. We don't want to throw it all away. And we want to maintain the patient's quality of life, meaning we don't want him to leak and we don't want him to be impotent. So we can boil it down into three things: erectile function, urinary control, and bowel control. This would be a lesion in the prostate, and if we could see it like we'd see a basal cell on a forehead, we go after that directly. Cryoablation, meaning that if we can establish that one side of the prostate is free of disease, we can leave the nerves alone over here, we can leave a good part of the urethra alone, and we'll freeze half of the prostate. If we're less certain, we may choose to free 75% of the prostate and still preserve some, but we're still trying to preserve erection function. I think we're individualizing oncologic care to a particular patient's need. That as we become more and more aware of the problem and look for it more intensely, the degree of problem we find becomes smaller and smaller. Treatment options. One size fits all. We live in a society that has folks that are a little bigger around the middle and a little thinner. And maybe one size doesn't really fit all as well as we'd like it to. And if we're talking about radical treatment, radical mastectomy, or in this case radical prostatectomy, maybe one size doesn't fit everybody. So what we really want is tailor-made treatment. Focal therapy offers the opportunity for tailored treatment for a particular type of prostate cancer. This is a gentleman who is out in California. His name is Duke Bond, and Dr. Bond has done a lot of work on cryoablation and its application to prostate cancer. This is from an abstract. Actually, this abstract was from Dr. Houari. They did 1,000 radical prostatectomies, and they looked at them all histologically, and they found that approximately, let's deal in round numbers, 20% had focal deposition of disease, nothing else. Index lesion. The index lesion in a prostate malignancy is the biggest lesion in the prostate. That there's a concept called insignificant prostate cancer. There was more to the story yet. Metastatic disease, or disease that spreads outside the prostate, is monoclonal, meaning that the cells are all genetically alike, meaning that those cells very likely came from one source. The index lesion is the largest lesion. If you have a multifocal lesion in a prostate, the largest of the lesions is referenced as the index lesion. And within the last 2 weeks, a journal article came out that essentially linked the monoclonal index lesion cells with the metastatic disease. So long story short, you could have multifocal small deposits of disease in the prostate, but it's very probable that the mover, the troublemaker, the bad guy on the block, you can identify because it's bigger than those smaller lesions in the prostate that we're for the moment going to call insignificant. And not only that, that means then that the index lesion histology, or the cell type, is what gives rise to the disease that migrates outside the prostate. And if you control that index lesion, you can eliminate about 80% of the risk of disease from a prostate that has more than one focus of cancer in it. There's a study called the CAPTURE study. It's a multi-practice study across the nation, and 94% of men with low-grade disease that probably did not require it had aggressive radical therapy. Now this is a biopsy system. This is a grid. I showed you that grid before when we were putting cryoprobes into the prostate. This is an ultrasound. This is a prostate. And basically you can get what we call a saturation biopsy. You can diagnose focal disease with multiple biopsies. If you have a select group of patients, as they did, about 48% of those patients that they thought were focal, in fact, were, and they could be treated in a limited way and get the same type of long-term outcome, good follow-up, as you did with the more radical treatments used on others. The biopsies we do in the office, though, are not the same as the biopsy system I just showed you. And you can't take the biopsy technique from the office and accomplish this goal. Okay, well, Judith Folkman was the gentleman who described angiogenesis. Angiogenesis is the growth of new blood vessels when you have tumor. This is the tumor. These are new blood vessels. What you'll start hearing about is contrast-enhanced ultrasound. And this is microbubble technology. And this can be administered intravenously. It will aggregate in areas where there is angiogenesis. Now, if we suspect prostate malignancy, we, by default, know that there's angiogenesis there. If you give microbubbles, look what happens. The site that has the angiogenesis lights up like a Christmas tree. You begin to see, local disease. It's getting back to the basal cell, it's getting back to the forehead, it's getting back to the idea if you can see it, you can treat it.